Praveen sir, can we start the recording, please? Dr. Naidu sir, please switch to full screen mode. Sir, can you please? Yeah, it's done, sir. Sonia ma'am.
Yes.
You can start with the introduction, ma'am.
Hello.
Hello, ma'am. You can start with the.
Hi. Am I audible, Shweta?
Yes, yes, you're audible.
Okay. Good afternoon. Currently working as Deputy Program Director with the Center of Excellence at PJEMER Chandigarh. Now I request Dr. Shankar to start the session. Thank you. Leishmaniasis.
Good afternoon, everyone, and thank you, Sonia, for the introduction. So, in today's session, I'll be speaking about the HIV co-infection with hepatotrophic viruses and leishmaniasis. So, the objective of the session is to understand about the HIV co-infection with both hepatitis B and C, and also about leishmaniasis co-infection. First, coming to hepatitis co-infections, as we all know that all the three infections, that is HIV, hepatitis B, and hepatitis C, share similar routes of transmission. These common routes of transmission are especially important in patients who are using IV drug abuse, and also those who are having men who are having sex with men. And these patients will have increased risk of acquiring hepatitis C infection. As far as the prevalence of these co-infections is concerned, from India, it has been estimated that the HIV and hepatitis C co-infection is somewhere around 6.2%, whereas hepatitis B and HIV co-infection is about 1.6% among PL-HIV. And it is important to understand these co-infections because the viral hepatitis has been shown to be the increasing cause of morbidity and mortality among PL-HIV, including those patients who are already taking ART. And concurrent and sequential infection of these viruses will result in more severe and progressive liver disease with a higher incidence of all the complications of chronic liver disease like cirrhosis, hepatocellular carcinoma, and related mortality. So first, looking at the hepatitis B and HIV co-infection, the estimated national seroprevalence of hepatitis B is somewhere around 0.95% in the general population. Whereas, as I've already highlighted, the prevalence among PL-HIV is somewhere around 5 to 6%. The risk of not all patients who develop hepatitis B infection will develop chronic infection. The probability of developing a chronic hepatitis B infection would depend on the age at which the infection has been acquired. It is as high as 90% in those patients who have acquired it perinatally, that is mother-to-child transmission. Whereas it is only about 5 to 10% among those patients who acquire it during adulthood. So acute hepatitis B infection is usually symptomatic with prodromal symptoms of fever, malaise, followed by development of jaundice and other symptoms related to hepatic dysfunction. However, a significant proportion of patients can be asymptomatic and may be undetected. So why it is important to understand this co-infection is that both hepatitis and HIV have a two-way relation with respect to the disease progression. So HIV affects the progression of hepatitis B, and hepatitis B infection affects the progression of HIV. So in this diagram, we can see the effect of hepatitis B on HIV progression. As we can see, as it was highlighted here, there would be a faster decline of CD4 count and also a slower recovery of CD4 count once we start the patients on ART. And these patients can also have an increased chance of developing immune reconstitution syndrome, presenting as hepatic flare. And also the co-infected patients have been documented to have higher rates of ARV toxicity and also increased incidence of AIDS and non-AIDS related events among these patients. And if you look at the effect of HIV on the hepatitis B infection progression, as we can see here, there would be rapid progression of these patients of hepatitis B infection resulting in cirrhosis, which is again a risk factor for developing hepatocellular carcinoma. And these patients have been shown to have a decreased treatment response. And all of these together will result in a higher mortality resulting from the liver dysfunction. So, who should be screened for hepatitis B co-infection? As a rule, all patients who are newly diagnosed with HIV should be screened with for hepatitis B infection. The screening test that is commonly used is the testing for hepatitis B surface antigen. So those patients who are found positive for hepatitis B surface antigen should be evaluated further with certain clinical examination findings and also various laboratory workup, which I'll be highlighting in the next couple of slides. So apart from the routine clinical evaluation, all patients who are co-infected either with hepatitis B or hepatitis C we should always look for signs of liver dysfunction and cirrhosis, and signs and symptoms of decompensated liver cirrhosis. And these include anything from jaundice to ascites to specific manifestations like spider angiomas, palmar erythemas, gynecomastia, testicular atrophy, and paratidomegaly. And also we should look for the presence of signs of hepatic encephalopathy like liver flaps, and presence of other specific findings like presence of prominent and dilated veins over the abdomen, and the presence of hepatic bruit and venous sums. So coming to the laboratory investigations, the routine investigations which need to be done at baseline in patients with co-infection would be hemogram, including CBCs, to look for the hemoglobin and the presence of leukopenia and thrombocytopenia, which may be manifestation of portal hypertension and splenomegaly. And also we should have the baseline liver function test, including the liver SGOT, SGPT, and serum albumin, and also renal function test, along with synthetic testing for liver involvement like the prothrombin time and APTT. Apart from this, we need to get alpha-fetoprotein levels which is a marker of hepatocellular carcinoma. Then ultrasound abdomen to look at the status of liver and spleen, and also upper GI endoscopy if there is an indication like upper GI bleed in the past. The specific investigation related to hepatitis B would be quantification of HBV DNA by doing the HBV DNA levels. All these investigations are needed for staging of the liver dysfunction. Previously, the staging would be done using the liver biopsy findings. However, newer non-invasive techniques have been developed, which include fibroscan, then using of the APRI, that is the AST platelet ratio index, and the fibrosis score, which includes the age of the patient, AST, ALT levels, and the platelet counts, and the Child-Pugh score, which includes the 5 components, that is presence of ascites, presence of hyperbilirubinemia, then prolongation of PT, then presence of hepatic encephalopathy, and presence of serum AST level. So the next question would be when should when should the ART should be initiated in these patients? So all HIV hepatitis B co-infected patients should start dual HIV and HBV therapy, irrespective of the CD4 count, irrespective of the HBV viral load or status of the liver disease. And as far as the treatment of hepatitis B is concerned, these patients should be linked to the designated treatment or a model treatment center as per the National Viral Hepatitis Control Program. This is mandated because we should ensure the provision of drugs for hepatitis B or C through linking them through these model treatment centers, and also necessary investigations and monitoring needs to be done related to the development of complications like cirrhosis and hepatocellular carcinoma. And the next question would be what would be the preferred ART regimens. Patients who are co-infected with hepatitis B and HIV the preferred regimen, the backbone should be, the NRTA backbone should include tenofovir plus which is combined with either lamivudine or emtricitabine. Irrespective of the stage of the liver dysfunction that is present in this patient. So if ARV drugs need to be changed because of drug resistance or toxicity developing because of the first-line therapy, then tenofovir and lamivudine should be continued together with the new ARV drugs. Because abrupt cessation of tenofovir or lamivudine would result in hepatic flares and also hepatic decompensation, which might lead to death of this patient. So whenever we are stopping tenofovir or lamivudine because of adverse effects, we should always look out for the development of hepatic flares in these patients. So as I've already told, when should we start ART? All patients who are diagnosed with HIV infection should be initiated on ART, irrespective of the CD4 count and irrespective of the hepatitis B staging. Hepatitis B viral load. Then choice of regimen again is TLD, which is in line with the preferred regimen for all other treatment-naive PL-HIV. And alternative regimens, like especially in patients who cannot tolerate tenofovir or developing toxicities, or where tenofovir is contraindicated, like patients who are having renal dysfunction. Those patients, abacavir can be replaced with abacavir can be given in place of tenofovir. However, we need to remember that we need to add entecavir along with lamivudine, because the drug of lamivudine against hepatitis B would result in development of drug resistance. So again, the alternative regimen, as I've already told, tenofovir to be replaced by abacavir, and we should use entecavir in place of tenofovir for controlling of hepatitis B. Whenever we are shifting these patients to second-line regimen, we should always continue the tenofovir and lamivudine, even if the patient has failed on these two drugs, which are a component of the first line, because this is to prevent the flares of hepatitis B among those patients who discontinue tenofovir or lamivudine. And HBV resistance, as I've already told, lamivudine is a drug which is well tolerated, but it has the potential of developing resistance very early. So if used as a single drug, the rate of resistance is somewhere around 50% by the end of 2 years, and as high as 90% by the 4 years of therapy. So always remember that lamivudine should not be used alone in these patients. It should always be combined either with tenofovir or entecavir. So those patients who have been started on therapy, they can have hepatic flares, and the cause for the hepatic flares could be either it could be an immune reconstitution manifestation because of initiation of ART, or it could be that there is a true hepatic flare because of discontinuation of any of the tenofovir or lamivudine. So we need to be monitoring these patients closely to differentiate between these two conditions, because the therapy would be different for both of these conditions. And if in a patient where you are unable to distinguish between these two conditions, it is always recommended to stop the ART as long as till the patient stabilizes, and then restart ART and then monitor subsequently. And as far as the lamivudine versus emtricitabine is concerned, both of them are equally effective. However, as emtricitabine is not provided in the national program, we are using only lamivudine. So the next step would be to about prevention of hepatitis B infection among patients who are not already infected with hepatitis B. So all patients who are testing negative for hepatitis B surface antigen and are newly diagnosed with HIV should be immunized with hepatitis B vaccination. And all infants who are born to hepatitis B positive women should be immunized with hepatitis B vaccine. However, hepatitis B immunization is not required if the patient is already infected with hepatitis B, or if there is a past HBV infection which has been treated and the protective antibodies are again more than 10 million units per ml. One important thing that we need to remember here is that the hepatitis B vaccine responses would be lower as compared to non-HIV patients, And these responses are much lower among those patients who are having a very low CD4 count. Hence, the dosage and schedule that is used may be different in these patients. The usual recommended dosage of hepatitis B vaccine is about 3 doses, 20 units in each dose. Whereas in patients who are found to develop a low response to hepatitis B vaccine, 4 doses of double dose of hepatitis B vaccine has been shown to be better than the three dose. Besides this, all infants who are born to hepatitis B positive women should receive 4 doses of hepatitis B vaccine, one at the time of birth within 12 hours, this is dose 0, then followed by at 1 month, 2 months, and 6 months. And also, they should also receive hepatitis B immunoglobulin 0.5 ml intramuscularly at the time of birth. So next, coming to hepatitis C co-infection. Again, as I've already told, the hepatitis C co-infection among PL-HIV is somewhere around 6%, 6.5%. However, hepatitis C accounts for nearly 12 to 32% of all cases of liver cancer and 10 to 20% of cases of cirrhosis of liver. And both of these conditions are associated with very poor outcomes, irrespective of the HIV status. So in this diagram, we can see the natural history of hepatitis C infection. As compared to hepatitis B infection, many patients who are infected with acutely infected with hepatitis C go on to develop chronic hepatitis C infection. Self-resolution of acute hepatitis C happens in only about 15 to 40% of these patients, and majority of the patients develop a chronic hepatitis C infection, out of which majority would be having a stable disease, whereas 10 to 15% will develop cirrhosis over a period of time. And among those patients who are developing cirrhosis, nearly 25% will rapidly progress on to develop hepatocellular carcinoma or a decompensated liver disease, which accounts to about 2 to 4% of the overall patients who have had an acute hepatitis C infection. So, again, the HIV and hepatitis C can have a two-way relationship. Both the HIV can result in rapid progression of hepatitis C infection, and also hepatitis C can result in rapid progression of HIV, also for impaired CD4 responses after starting ART. And these co-infected patients will have accelerated progression to cirrhosis, accelerated progression to decompensated liver disease, and also development of hepatocellular carcinoma. So this is almost similar to the co-infection relation between hepatitis B and HIV co-infection. So it is recommended that all patients who have an history of IV drug abuse, or those who have a history of multiple blood transfusions, or those with elevated liver enzymes, or a strong clinical suspicion of having hepatitis C infection, should be screened for chronic hepatitis C. The recommended test is testing for the detection of anti-hepatitis C antibodies. Usually, anti-hepatitis C antibodies develop during the acute HCV infection, and they usually persist throughout the life, irrespective of the status of the hepatitis C infection. So, even among those patients who have cleared the infection on their own at the stage of acute hepatitis C, can continue to have these antibodies. So, to confirm a presence of chronic hepatitis C infection, should always test the HCV RNA levels and then confirm the diagnosis of chronic hepatitis C. This is slightly different from what we follow for hepatitis B, where hepatitis B surface antigen detection would entail the initiation of anti-HBV therapy, whereas in hepatitis C, presence of just anti-HCV antibodies is not enough. We should always confirm the hepatitis C infection, chronic hepatitis C infection, by testing the HCV RNA levels. Again, the clinical evaluation, laboratory testing, and other basic workup is similar to that what we have seen with hepatitis B co-infection. And also, we should stage the liver disease as per the child severity of the liver dysfunction. So regarding therapy for hepatitis C, previously interferon and ribavirin were used in combination, and this combination therapy was associated with a lot of side effects. So not many patients would tolerate this combination, and also the response rates were not as good as that we see nowadays. Because recently, for the last few years, hepatitis C treatment has been revolutionized by the use of direct acting antiviral, and the sustained virological response rates with direct acting antivirals was almost similar to that with non-HIV patients. And regarding the therapy of hepatitis C, all these patients who are co-infected should be linked to the treatment or model treatment centers under the National Viral Hepatitis Control Program, as these treatment model centers provide free treatment and free evaluation for all patients with hepatitis. And the decision when should we start ART in this patient, the decision to start ART among people co-infected with HIV should follow the same principles as for HIV monoinfection. So this is an algorithm taken from the NACO 2021 guidelines regarding the testing of various hepatotrophic viruses in presence of jaundice. So for hepatitis B, as I've already highlighted, we should screen with hepatitis B surface antigen, and also we should also test for the IgM anti-hepatitis B core antibody. So this will give an idea about the stage and replicative phase of the hepatitis B infection. And regarding HCV, it is again anti-HCV. If they are positive, then we should confirm it with HCV RNA level. So this algorithm is for patients who are suspected to have hepatitis but are not having jaundice. So which is almost similar to that what we have seen in the previous diagram. So regarding the management of hepatitis C infection, the 4 direct acting antivirals that are available under the national program are the sofosbuvir, daclitazavir, velpatasvir, and the ribavirin. So treatment is currently recommended for individuals who are 18 years or old, and the timing and choice of regimen is influenced by the stage of the disease, and also where these patients need to be treated, depending on the stage of the liver disease. So all treatment-naive patients with hepatitis C without cirrhosis and complications, which form a major chunk of the chronic hepatitis C patients, are managed at the designated treatment centers. While complicated cases and patients who have already failed initial therapy are to be managed at the model treatment centers under the national program. So once we do the basic workup for liver dysfunction and we stage the patients as per the child book score, then we can decide whether this patient and once we know whether these patients are having cirrhosis or not having cirrhosis, then the treatment regimen can be decided. So in patients who are not having cirrhosis, the treatment regimen preferred choice would be sofosbuvir plus daclitazavir for 12 weeks. Whereas patients with cirrhosis with child book score class of A, that is mild or early stages of cirrhosis, they are given sofosbuvir plus velpatasvir for 12 weeks or 3 months. And after the end of 12 weeks, we need to repeat the HCV RNA levels. And if they are not detected, then we complete the therapy. Or if the HCV RNA levels are still elevated at the end of 12 weeks, then we need to refer to a higher center or the model treatment centers as per the under the National Viral Hepatitis Control Program. And the preferred regimen for patients who are having severe decompensated cirrhosis, which fall into child score B or C, would be sofosbuvir plus velpatasvir plus ribavirin. So in patients who are having child book score B or C cirrhosis, in addition to sofosbuvir and velpatasvir, we add ribavirin for a duration of 12 weeks. If patients are not able to tolerate ribavirin, then we are going to treat them only with sofosbuvir and velpatasvir for a total of 24 weeks, that is 6 months. So certain rules that we need to follow in patients with co-infection of hepatitis C and HIV are before we start HCV therapy, we should always stabilize the HIV infection clinically. While the direct-acting antivirals have revolutionized the treatment of hepatitis C and significantly improved their outcomes, there can be significant drug-drug interactions between these antivirals for HCV with those of the drugs that we use for controlling HIV infection. So we should have a knowledge about these important drug interactions, which I will be showing in the next slide. And the decision to start ART among people co-infected with HIV should follow the principles as for HIV monoinfection, which I've already told before. And the preferred regimen is same as that for all treatment-naive patients of HIV, that is TLD, tenofovir, lamivudine, and dolutegravir. And there might be a potential harmful effects of ARV drug initiation with relation to worsening of the hepatic dysfunction. However, it has been shown that the benefits of treating both HIV and HCV with various antivirals outweigh the concerns regarding this drug-induced liver injury. So, no patient should be denied therapy for both these infections, irrespective of the status of the liver dysfunction. So, this is the chart showing the various drug-drug interactions. So, I'm just going to highlight only 2 points in this chart. As most of the first-line regimens contain the tenofovir, especially as per the National Hepatitis Control Program. We may use sofosbuvir and velpatasvir in these patients. Ledipasvir is not available through the program, so we might not be seeing this combination usage. So, as far as this combination of sofosbuvir and velpatasvir, these can result in increased levels of tenofovir. So, we should monitor very closely for development of tenofovir-related toxicity in these patients. And also the boosted PIs like atazanavir, ritonavir, darunavir, ritonavir, and lopinavir, ritonavir. These patients also, if they are on sofosbuvir and velpatasvir, we should monitor for the development of tenofovir-associated toxicity. And patients, drugs of NNRTI class, that is efavirenz and nevirapine, are contraindicated along with sofosbuvir and velpatasvir. So these 2 points need to be kept in mind. And regarding the monitoring of these patients after we start therapy, regular monitoring of both liver and renal functions is required while the patients are on dual therapy. And additional monitoring of liver function is required in presence of cirrhosis. And patients who are having cytopenias in the form of neutropenia, thrombocytopenia, and anemia, they require monitoring every 1 to 2 weeks. And as far as the prevention of hepatitis C is concerned, in those patients who are not already infected with hepatitis C, there are no effective vaccines available for preventing hepatitis C. So we need to stress about practicing safe sexual behaviors and also strict maintenance of disposing the needles and not sharing the needles with other people in patients who are IV drug. So coming to the third part of the lecture, that is the HIV and leishmania co-infection. So leishmaniasis is a vector-borne tropical disease which is caused by more than 20 species of protozoan parasite, that is leishmania. And it can present with various forms. The severe form would be involvement of various systems, the form of visceral leishmaniasis or kala azar, or it can present with mucocutaneous leishmaniasis or just a cutaneous leishmaniasis. So worldwide, annually about 50,000 to 90,000 new cases of visceral leishmaniasis are documented. With as per the 2018 data, 95% of these patients are reported from these 10 countries, which includes even India. Whereas the annual incidence of other forms of leishmaniasis like cutaneous leishmaniasis is much more than visceral leishmaniasis, and mucocutaneous leishmaniasis has been predominantly reported from South American countries like Brazil, Ethiopia, and Peru. So this map shows the countries with highest burden of visceral leishmaniasis. As you can see, dark brown indicating more than 1,000 cases reported during 2018. And India is one of the country where more than 1,000 cases have been reported in 1 year. However, we need to remember that the burden of this disease is not uniform throughout India. There are certain areas where the disease is mainly seen more commonly than compared to the other areas. So among these, the visceral leishmaniasis is very common in the eastern states, including Bihar, Jharkhand, Uttar Pradesh, and West Bengal, with Bihar contributing to more than 80% of all the cases seen in India. So in these four states, nearly 165 million people are at risk of developing visceral leishmania. Apart from this, various small pockets of cutaneous leishmaniasis has been reported from Rajasthan, Himachal, and Kerala. So as I told, it is a vector-borne. The vector that transmits this infection to humans is a sandfly, which is Phlebotomus or Lutzomia. Phlebotomus argentypes is considered to be the vector in the old world that includes the Europe, Africa, and Asia. Whereas Lutzomia, which is another type of sandfly, is responsible for transmission in the New World, which includes the Americas, both the continents of America. So, visceral leishmaniasis is caused by visceral Leishmania donovani complex, which includes Leishmania donovani, which is the common species of Leishmania seen in Indian subcontinent and Africa. In Europe and other New World countries, it is the Leishmania infantum, which is the positive agent. And Leishmania exists in two forms. One is the promastigotes with a single flagella, which is an infective stage for human, and an amastigote form, which is without flagella and which is usually seen intracellularly within the macrophages. And this is the amastigote form is what we see within the human. So this again is highlighted in this life cycle of Leishmania. As we can see from here, the first step is that the sandfly, which is infected with Leishmania, they contain the promastigote stage, which when these sandflies bite the humans, they transmit the promastigote forms of Leishmania into the blood of the humans. And these promastigotes are phagocytosed by the macrophages, where these promastigotes are transformed into amastigote form, and they keep on replicating within the macrophages, resulting in various clinical manifestations. So once these infected macrophages disseminate throughout the body, especially the reticuloendothelial system, which includes the spleen and other bone marrow and other organs, they result in various manifestations of visceral leishmania. So when a sandfly bites an infected human, they ingest the amastigote forms which are present within the cells of the macrophage, cytoplasm of the macrophages. So these enter the gut of the sandflies, and within the gut they come out of the macrophages and they develop into promastigote stage within the midgut of the sandflies, and they replicate within the midgut, and then they again bite a new individual where it is again transmitted to a new individual. So the transmission of Leishmania can be in the form of two things, that is anthropootic, that is from your sandfly to human, or zoonotic, where it is predominantly from the animal reservoir, that is domestic dog. And cutaneous leishmaniasis mostly has zoonotic transmission, except for the cutaneous leishmaniasis, which is caused by Leishmania tropica. And visceral leishmaniasis and the post-Kala-Aza-dermal leishmaniasis is mainly transmitted through anthropootic transmission. So coming to the pathogenesis, the parasites, as I've already highlighted in the life cycle diagram, the parasites replicate in the reticuloendothelial system, and these accumulate within the spleen, liver, and bone marrow. And the infiltration of these infected macrophages will result into the bone marrow will result in pancytopenia, and within the spleen will result in massive splenomegaly, which may again contribute to the pancytopenia in the form of severe anemia, and also hemolysis and sequestration of RBCs within the spleen. When they involve the hepatic liver, they present as hepatic dysfunction in the form of jaundice and ascites. However, hepatic dysfunction is seen very late in the course of the disease, and they can have bleeding manifestations either because of thrombocytopenia or because of hepatic dysfunction resulting in coagulopathy. And sometimes patients can have atypical manifestations in the form of GI involvement and malabsorption, resulting in chronic diarrhea, especially if the amastigote form are invading the intestines. So coming to the clinical features, fever with rigors and chills is a typical manifestation of visceral leishmaniasis. They can present with cytopenias, which can be anemia, thrombocytopenia, or leukopenia, and massive, mild. Usually they have moderate to large spleens. Then they can have jaundice if the liver involvement is significant, and they have a high immunoglobulin levels, and all the cytopenias can result in immunosuppression, and this can predispose to secondary bacterial infection. And these secondary infections can be in the form of bacterial pneumonias, tuberculosis, herpes zoster, scabies, or various GI infections, including amoebiasis, bacillary dysentery, and various forms of gastroenteritis. The incubation period lasts from anywhere between 10 days to over a year, and typically it is between 2 to 6 months. And the main clinical features of visceral leishmaniasis, as I already highlighted, it is fever, cytopenias, weakness, weight loss, and massive splenomegaly. So, which is already depicted in this figure here, where you can see the marking of the spleen. Such huge spleens are common in patients with visceral leishmania. Among the other features, soft cough, dry, watery diarrhea, pancytopenia, and hypoalbuminemia can be seen. And even though enlarged lymph nodes can be seen, it is not common in Indian patients with visceral leishmaniasis. Lymph node enlargement is commonly reported in the African variety of leishmania. The skin can be dry, thin, or scaly. There would be hair loss, and there would be grayish discoloration of the skin over the body, and this has given the name Kala Azar to this particular disease. And deaths usually occur because of opportunistic infection or concomitant infection because of resultant immunosuppression. So, post-Kala Azar dermal leishmaniasis is another condition which develops in about 5 to 10% of patients who have been treated for visceral leishmaniasis in the past, and they have macular, papular, or nodular rash over the face, upper arms, trunk, and other parts of the body. And it usually develops 6 months to several years after apparently being cured from Kala Azar. It is important to identify this condition because patients with post-Kala Azar dermal leishmaniasis can be a potential source of infection. Hence, they need to be identified and treated early. Coming to HIV and leishmania co-infection, the estimated prevalence is about 2 to 5.6%, with leishmania, and also certain typical characteristics do happen in these patients who are co-infected. The leishmania amastigotes survive and multiply within the macrophages, and this replication of leishmania amastigote forms is enhanced by co-infection with HIV, and there will be accelerated progression of leishmania acquiring leishmania infection to the severe manifestation of leishmania. Compared to HIV negative individuals, the risk of developing visceral leishmaniasis is between 100 to 2,300 times higher in PL-HIV. And there would be challenges in patients who are co-infected because certain immunological characteristics resulting from HIV infection may result in different manifestations of leishmania in PL-HIV compared to non-HIV. Sometimes these manifestations of leishmaniasis, atypical manifestation of leishmaniasis, can resemble various other opportunistic infections, resulting to misdiagnosis of it being a different OI and inappropriately treating for those OIs. The atypical manifestations can be because of seeding of amastigotes into the unusual sites, which are not the common sites for the dissemination of Leishmania parasite. These include GI and oral mucosa, skin, pleural cavity, pericardium, and lymph nodes, and the respiratory. So if these unusual sites are infected by these parasites, then they can have those manifestations which are not commonly seen in non-HIV patients infected with Leishmania. So this again highlights the thing that I've already told you. Parasitic dissemination can happen, especially if it is disseminating into the skin, can develop diffuse cutaneous leishmaniasis, or if they are through the reticuloendothelial system, it can result in various manifestations of visceral leishmaniasis. And the atypical location, presence of these amastigotes in the atypical location can result in various atypical manifestations which are not commonly seen in non-HIV patients. And this is mainly because of the impaired cell-mediated immunity seen in patients with HIV. And HIV and Leishmania co-infected patients have multiple relapses even after giving proper treatment for Leishmaniasis. And also they will have a poor response to standard therapy. And they also don't develop anti-Leishmania antibodies. So it might this might challenge the diagnostic modality that we use for diagnosis. So definition of a suspected case of Kala-Azar is a patient who is presenting to us with a history of fever, which is there for more than 2 weeks of duration, with a splenomegaly, with or without hepatomegaly, and is not responding to therapy for usual causes like malaria and other antibiotics. And especially if the patient is coming from the endemic area, which are the 4 states that I've already informed you, that is Bihar, Jharkhand, UP. UP. So a patient with above symptoms with who is being clinically examined by a doctor and found to be positive by the rapid diagnostic test for Leishmania, that is RK39 antibodies. Then in cases with past history of Kala-Azar, or in those with high suspicion for Kala-Azar with negative RDT, but on examination of the bone marrow or splenic aspirate, we can demonstrate the presence of Leishmania Donovani bodies. So this is an image showing the LD bodies, that is Leishman Donovan bodies. These are nothing but the presence of intracellular intracytoplasmic amastigote forms within the macrophages. So this is called as LD body, and once we demonstrate this LD body either in the bone marrow or the splenic aspirate, it gives a confirmation about the presence of Leishmania infection. So coming to the management of visceral Leishmaniasis, the recommended treatment regimens include liposomal amphotericin, other antimonial compounds like paramomycin and miltefosine. As far as the dosage of amphotericin B is concerned, the dosage and the regimen depends on the formulation of amphotericin. With liposomal amphotericin B, single dose at a high dose of 10 milligrams per kg has been shown to be very effective in curing these patients of Leishmania infection. The alternative regimens would be 10 days of a combination of intramuscular paramomycin and oral miltefosine. The paramomycin is given at a dose of 11 mg per kg, whereas miltefosine, the dosage is based on the age and weight of the patient. In children, it is about 2.5 mg per kg per day, whereas in adults, it is either depending on the body weight, either 100 milligrams per day in divided doses or 150 milligrams per day in divided doses. If liposomal amphotericin B is not available, we can still use the conventional amphotericin B deoxycholate at a dose of 0.75 to 1 milligram per kg. For a total of 15 infusions have to be given. We can give them either every day or an alternate day over and to be finished within 30 days. So as far as HIV and visceral leishmaniasis co-infection is concerned, The current guidelines say we should use a higher dose of liposomal amphotericin B, which is given at a dose of 4 milligrams per kg per day. A total of 10 doses are to be given. The first 5 doses are daily, that is day 1 to day 5. Then weekly from day 10, day 17, day 24, day 31, and day 38. So this would give a total cumulative dose of 40 milligrams per kg of liposomal amphotericin. This is against the recommended dose of 10 milligrams per kg in non-HIV infected individuals. For the post-Kala-Azar dermal leishmaniasis, miltefosine is recommended. The dose I've already shown in the previous slide. Apart from that, liposomal amphotericin at a lower dose, that is 5 mg per kg per day, 2 times a week, for total of 6 doses. That is over 3 weeks. You have to give 6 doses. And liposomal amphotericin B conventional at a dose of 1 milligram per kg. Total of 60 to 80 doses over 4 months can be given. Regarding the cutaneous leishmaniasis, intralesional antimonial compounds or azoles or cryotherapy can be used. Cutaneous leishmaniasis, it is important to identify these lesions in HIV, PL-HIV, because even though the cutaneous leishmaniasis manifestations are very rare, they can be a characteristic manifestation in HIV and visceral leishmaniasis co-infected patients. And it is seen in about 2 to 12% of patients with this co-infection. And these can be in the form of lesions can be evolved from the papules to nodular plaques to ulcerative lesions, which may be painful or may not be painful, with raised border and central depression. And these lesions can be covered by a scab or a crust, and some lesions can persist as nodules. And skin lesions these kind of lesions can persist for more than a month. In some patients can persist for even years. And mucocutaneous leishmaniasis is another rare form seen in about 2 to 3% of all cases of HIV leishmania co-infection. All the leishmania species can cause mucocutaneous leishmaniasis. And the typical involvement would be involvement of the nasal septum and soft palate. These might be seeded secondary to infection present somewhere else in the body, or these can be the primary lesions in these patients. And for the diagnosis, a nasal biopsy from the specimen is commonly needed to elucidate the definitive diagnosis. So that ends the today's session. And if there are any questions or any other clarifications needed, participants are requested to ask. So, do we have any questions or? So if there are no questions, can we end this session?
Yes, sir. Thank you so much. Thank you, sir.
Okay.